for various reasons. And if there are surgically correctable problems, because infertility can be many things, can be medical related, can be male related, can be so many. But if it's a surgically corrected problem, then we find that the results we can able to give patients with robotic assisted surgery is much better. And the more we do, we realize that that's really making a difference there.
I mean, the motto in my theater, you know, in the UK, is the impossible made possible. So we all know that minimally invasive surgery is better for the patient, from outcome, from recovery, from length of stay in the hospital. And then you'd say, why is the robot if you're doing something with the standard sticks? The robot is still a laparoscope with, I'd say, like the laparoscope is on steroids. You see in 3D vision, you're immersed. As a surgeon, you're like the maestro, like Roma just said. She's basically in control of the camera and the instrument, so that means she knows what's the next step of her surgery. Before, you know, she cut down her operative time by 25%, you know, because she knows what's the next step. You're not relying on another colleague, okay, move here, move there, take the camera out, take the camera in. And yes, so incidence of disease, obesity is becoming a major factor internationally, you know, not in India only. Obesity brings disease and challenges to women from polycystic ovarian syndrome, from cancer, you know, and this is where you need an instrument that will allow you as a surgeon to operate in these complex procedures, and where the robotic platform compared to the standard laparoscopy, the advantage, you could work on these super obese women without having to worry about your anesthesis fully, because to us the challenge always been the anesthesis. When you operate in the pelvis, if the patient lie flat, all the bowel is in there, so you need it in a head position. That gives the anesthesis extra challenge. With the robotic platform, you have the arms will lift in the abdomen, so this machine, the patient's cart is lifting the abdomen, so you could work with less pressure, and then you could do quicker surgery, and then that means advantage to the patient. But take it also to some challenges we used to have in benign non-cancer patients, like anything you want to operate from distance. When you hold in the instruments with the standard laparoscopy, your hands are shifting, you know. Open surgery, you cannot see as much, you know, because we know minimally invasive surgery, you have the gas, helps you to go into spaces. With the robot, you have the advantage of the straight stick surgery. On top of that, your instruments, they help with the machine so they don't move at the tip, because if you're holding something from here, the tip starts shaking. They don't move. That means you're more precise and you can do better surgery.
I would now invite, we will give you two more insights. Dr. Yogesh, he's a gynecological oncology surgeon from Mumbai. What is your impression in your practice? How you think for women suffering from uterine and cancers, how do you think you have been helping? And then I will ask Dr. Anwar to give a little insight as to how we are taking the training of our surgeons to a higher level, because we are now collaborating with the European surgeons to this. So Dr. Anwar after that will tell you.
Yeah. So I think as far as oncology concerned, as far as cancer surgery concerned, there was always a concern whether you are doing the same quality of surgery by using minimal invasive technique, be it laparoscopy or be it robotic surgery. I think there have been a lot of studies that have dispelled this, that okay, minimal access surgery is as safe as open surgery. So cancer surgery, whether you do open or whether you do keyhole surgery, the outcomes are the same, barring few cancers. That was one. Now the second part is, we should not consider robotic surgery as a competition to laparoscopy. We should look at it as evolution of technology. So the problems that surgeon faced by doing the conventional laparoscopy, the robotic surgery is trying to overcome that. And technology is going to move. 10 years down the line, there is going to be a new equipment and this technology would be outdated. So that's how we have to look at it, because bottom line is the only way surgery as a specialty can evolve is by you are trying to do the same job with least collateral damage to the patient, and that should be the aim of technology evolution. And that's where so that's why I call, as of today, robotic technology is something which is most friendly both for the patient as well as for the surgeons.
Thank you, Yogesh. Any more questions? Okay, I'll just ask Dr. Anuva, who is our executive committee member as well, who's been working very hard for the last few months on getting this Indo-European training program organized. He'll just give you a brief of how we are planning, because that's the most important responsibility of our association. Anuva, can you please?
Thank you, ma'am. Welcome, everybody.
That is the information about it.
Yeah, good afternoon, everyone. So, just to answer this question about training, just I would like to add one point over what they have said. That a very important point is that training a surgeon for robotic surgery has a much shorter learning curve than in laparoscopy. It takes less time to produce a good robotic surgeon than a laparoscopic surgeon. A laparoscopy training, to master a surgery in laparoscopy, takes many more years of time than to do it in robotic, because of the ease of operating and also the way it mimics open surgery. That's why it is much easier to learn. So even some people say that you can move from open surgery to directly to robotic surgery without going through laparoscopic surgery. So when we hatched this plan of this program, which you see on the screen, we had the issue in hand that what he asked. What about training? You have the technology, you have the surgeons, who will train them? The major problem of training in India, or rather I will say worldwide, was access to training. There are many surgeons who are very eager to learn new things, but they don't have the access to training, because the system that is persisting in most part of the world is that you get to train when your hospital has a robot. And your hospital administration decides who are the surgeons who are going to go for training. There will be maybe 50 surgeons in a hospital. All will not get the chance to get on the robot, but all of them may have the wish to do so. And that is where we thought that there is a role as a society to give it back, just like Madam said. And we thought that we should take advice and guidance from a society who is already doing it for a few years earlier. So we joined hands with the European Society so that we could formulate a course which will work only with the aim of creating safe robotic surgeons. The only aim is creating safe robotic surgeons. They should be operating safely on our patients. That is the major concern, patient safety. So they are going to go through this course. There are 3 levels of this course. There is option for gynecologist or gynecologist at all levels, someone who is in training to someone who is already doing robotic surgery, to join this course at various levels. For beginners it's level 1, for advanced it is level 3, and it will ultimately culminate into a diploma in gynae robotic surgery, which will be jointly conferred by both the societies. It is a very stringent training. There is no laxity in it. We have taken all measures to ensure that there is no dilution in quality. So they will be trained in small batches. We aim to do that again to ensure that we produce master safe surgeons who will operate on this machine to give the best back to our patients. Thank you.
Thank you, Anuva.